Here are my 3 minutes on surveillance colonoscopy in inflammatory bowel disease. First off, where possible, use the best equipment available to you. A high-definition system improves dysplasia detection rate when compared to standard definition by up to 2-fold, with recent evidence suggesting that high-definition white light endoscopy is comparable to chromoendoscopy. Nevertheless, dye-based chromoendoscopy remains the recommended way to optimize dysplasia detection. On withdrawal from the cecum, I use INDIGOCARMINE at a concentration of 0.03%, with either a spray catheter or a foot pump, and typically I spray this along the anti-gravity wall, which is an efficient way of achieving better coverage. I then deflate and reinflate the lumen to improve the spread of the dye further before re-inspecting that segment. I then work distally, aiming to inspect 20 to 30 centimeters at a time. A likely alternative to this in the future will be digital chromoendoscopy using image enhancement modalities such as MBI, iScan, or BLI. When it comes to biopsies, my preference is to take targeted samples rather than random biopsies, although there is still some conjecture about this. It's thought that 90% of dysplastic lesions are visible, and as such I favour a targeted approach, but recognising dysplasia can still be difficult. Fundamentally, I look for an area that looks different to the surrounding. Does it appear elevated or depressed, and does it have a different colour? Does the surface pattern appear different? Once you've suspected dysplasia, it's then important to characterise the lesion, and using a more concentrated spray of the dye can help with this. We no longer use terms such as DALM or sporadic adenomas, and instead, if visible dysplasia is found, characterise the lesion initially by its morphology. Use the modified Paris criteria to describe whether it's polypoid or non-polypoid, and whether there are features such as a depressed area that might represent a higher risk of deeper submucosal invasion. Assess how large the lesion is and whether or not the lesion has discrete borders, and then finally document whether there's any surface ulceration and what the background mucosa appears. And ultimately, this will help you decide whether the lesion is resectable or not. Unresectable lesions are typically those with indistinct borders or that are poorly circumscribed, with a depressed surface or an amorphous surface, and these lesions should be biopsied with sampling focusing on the most concerning areas and a tattoo placed in close proximity. These lesions will ultimately likely require a surgical intervention. If the lesion is resectable, consider its size. For lesions less than 2 centimeters, a standard polypectomy or an en bloc EMR would be entirely appropriate, but can be difficult owing to the submucosal scarring from previous inflammation. Often these lesions will demonstrate a non-lifting sign, even if not malignant. If the lesion has been removed, take biopsies from the surrounding area and consider placing a tattoo if there are any suspicious features. For lesions larger than 2 centimeters, piecemeal EMR is an option, but has a reasonably high recurrence rate, and so en bloc resection with an ESD does provide an attractive alternative. Finally, it's important to acknowledge that decision-making regarding dysplasia requires a multidisciplinary team. While some patients can be managed with an endoscopic approach, others, such as those with multifocal disease and previous high-grade dysplasia, may benefit from surgery. And those are my 3 minutes on surveillance colonoscopy in IBD.